Welcome you all once again for this case discussion. Today we are going to discuss on acute ischemic stroke. Okay, first I will go through one case here. 59-year-old man with history of atrial fibrillation, hypertension, and diabetic. Awakes at 7 a.m. and is noticed to have garbled speech and weakness 2 by 4 of his right arm and leg. So he is unable to stand without full assistance and cannot lift his arm against gravity. He went to sleep at 10 p.m. the previous night and made a trip to bathroom at 5:45 a.m. His wife asked him where he was going. He was able to answer and she looked at the alarm clock, then went back to sleep and then woke up at 7 a.m. So he takes aspirin, insulin, enalapril, metoprolol, and warfarin. So he has had CABG 3 months ago. Okay, this is the history, and he is rushed to ER with the BP of 200 by 110. He looks to the left and does not follow commands and makes incomprehensible sounds, and he is right hemiplegic. When he reached emergency, GCC is 9, lungs are clear. This is the history of case. Okay, so with the earlier known case of atrial fibrillation, hypertension, diabetic, coming with the right side weakness and difficulty in speak. So my question here is, so this is a case of stroke. What is the stroke chain of survival? Anybody like to be interactive session? Whatever you know, you can answer here so that we can discuss from there. So what is stroke chain of survival? You know that in basic life support, advanced cardiac life support, we have chain of survival. Okay, even myocardial infarction, we have chain of survival. We have a timing and we want to manage the patient with as early as possible. Okay, so anybody want to answer this question? What is the stroke chain of survival? Okay, anyone, let it be interactive. So you have to understand the chain of survival is like we do for ACLS. Okay, we have a chain of survival. So somebody is answering here. So early recognition, very right. So any stroke patient. So remember, early recognition is the key. Very important. Early recognition and management. So here we have detection, patient or bystander recognition of the stroke signs. So even in ACLS we teach how to identify stroke by using the mnemonic FAST, and dispatch to the to the hospital where we can manage that acute ischemic stroke, most appropriate stroke hospital. That is very important. So we cannot shift the patient anywhere where there is no stroke protocols are followed, or they are not equipped with managing stroke patients. And this is important, immediate ED triage. So what to be done in emergency department, that is also we have based on timing and getting the data, evaluation, stroke team activation, and some blood tests and brain imaging. This is very important, early imaging, so that we can decide for most appropriate therapy. If it is a ischemic stroke, we want to thrombolize if the patient is in window period. If the patient is not ischemic stroke, then it may be hemorrhagic shock, or sometimes maybe subarachnoid hemorrhage also. If it is a ischemic stroke or any other stroke, see whether what drugs to be given, and then timely admission to the stroke unit. This is called 8D, 8D stroke chain of survival. I mean this basic thing how to go about this patient. That is called stroke chain of survival. Why it is important? Anybody just let it be interactive. Why we are timed everything here? Anybody want to answer? Nesara, you want to answer why this is very important stroke chain of survival?
To recognize early and no, as time is brain,
Yes, very
if the
good.
candidate.
You rightly told time is brain here. Okay, time is brain. You can see here per stroke. You can see per stroke the 1.2 million billions will, neurons will be lost when there is acute ischemic stroke is there. Okay, you can see here synapses lost is 8.3 trillion and myelinated fiber loss is significant. And aging, you see the aging here 36 years means as time passes, when there is a stroke is there, when there is a clot obstructing the blood flow to the respective brain parenchyma, the ischemia starts, that is causing the neuron loss per hour, per minute and per second. You can see per second 32,000 neuron loss. So we call it as time is brain. Like we call even time is in the heart patient we call time is muscle. Here it is we call time is brain. Very important. And this time is not same for all patient. So there is even studies are showing within 4.5 hours we want to thrombolize. Okay, 4.5 hours. Sometimes it may be varies. Even sometimes have different timings. I will discuss that part. So why ascertain the time of onset as when we should know the time of onset of symptoms when the patient is seen normal is very important. So here when the patient is seen normal, can anybody tell this? So I'll go through the case once again. See here, he went to bathroom at 5:45. That time he was seen normal, but when he wake up at 7 a.m. he had a stroke. So we have to consider 5:45 a.m. as a loss in normal, not the timing when you went to sleep. Sometimes if he not woken up during night, then we have to consider the time when he slept, exactly like a 9 p.m., 10 p.m., 11 p.m. That timing will be last seen normal. I think you are understanding this. It is a very important concept here. Time is the brain. We want to see, the onset of symptoms. So how do you time the ED based care? Anybody want to answer this? How do you time the ED based care? So this you have to understand. When the patient comes to the emergency, within 10 minutes, physician should see the patient within 10 minutes. Remember this. And if stroke team is there, within 50 minutes, you should see the patient, door to stroke team. CT should be done within 25 minutes. At least you start CT doing within 25 minutes. And CT interpretation should be done within 45 minutes. So that within 1 hour, we can go for drug to door to drug therapy, that is TPA, tissue plasmin activator, can be given within 1 hour, and door to stroke admission within 3 hours. So this is very important. Within 1 hour, we want to do most of the things so that we can get a better benefit. If you do it early, it's best. Okay, if you know the case, if you're directly shifting to the, sometimes shift to the patient directly to the, instead of ED, you can go for directly to the CT room. Before shifting to CT, you can examine the patient, you can call for stroke team there, start doing CT within 10-15 minutes. Even you can thrombolize there also if the BP is satisfactory, if the parameters are satisfactory, if it's not a contraindications. Okay. Okay. This is very important. ED based care. So timing is very important. That's the thing I want to explain here. Then enumerate clinical situation mimicking stroke, and how do you rule out? So you have seen one patient now with right hemiparesis and going for right hemiplasia, and ED is already in right hemiplasia. There is no power. So what are the clinical situations within 10-15 minutes you want to evaluate? Anyone be interactive so that it will be easy for me to discuss in detail. Shikil Pal, you want to answer this? Shiv Shankar Bhatt? So here, as we mentioned, time is brain. We cannot do in detail examination, but try to evaluate you know, the clinical situation which is mimicking stroke. This is called stroke mimics. Stroke mimics should be ruled out before considering the all these things. One is psychogenic, okay, seizures, post-ictal state, that is a very important. Hypoglycemia, this is the most important investigation to be done is glucose before thrombolizing any patient. Glucose is the most important thing. We have to do the testing. Without glucose, don't thrombolize. Okay. Hypoglycemia, if history of diabetes, low serum glucose, decreased oil conscious, this is very important. Obviously, you have to rule out seizures. This is the most important investigation to be done. Glucose, migraine, if any similar events earlier, hypertensive encephalopathy, patient will be delirium, hypertension, cortical blindness will be there, wernicke encephalopathy, there will be alcohol abuse history will be there, CNS abscess, this patient, there a long history will be there, gradual progression of the symptoms in CNS tumor and drug toxicity. So try to evaluate as early as possible stroke mimics. At least you are able to remember few things, so that basically seizures you have to rule out, hypoglycemia should be ruled out, hypertensive encephalopathy should be ruled out. Sometimes patient may be psychogenic, he is just acting, okay? So you have to see, that is very important. And drug toxicity if possible, very rarely present like a stroke, but you have to remember that, especially cocaine, hypertensive bleed can cause, lithium, phenytoin can cause. Okay, after understanding the uh, you know um, what I'm selling is the stroke mimics, we have to do stroke scale. This is very important. Stroke scale or scores, you have to examine the patient that within 15 minutes, as I mentioned here, 15 or sometime 20 minutes, you have to examine the patient and see stroke scale or examination. So we have to remember this score that is called NIHSS, NIH stroke scale. So it's a very important scale. So all patient in coming to the ED, emergency department or ICU, go through this, make a chart and see that whether what is the severity of the score. This tells the severity of the score. So the moment the patient comes, try to diagnose acute stroke, try to rule out stroke mimics and assess neurologically. That is very important. In this you can see we have a lot of parameters are there. Level of consciousness is there, okay, and your patient is, I will discuss this part. There's some, you can, these are the things, you can show them whether able to answer these things like a stroke. This is item 9, best language, whether he can identify the picture or not, whether he can able to tell these words or not, mama, tip top, 50-50, these words. So to assess neurologically, so in detail you should know, everybody should able to understand this you have to keep in your ICU and emergency, so that you can diagnose, you can say, tell the severity. This is the one, okay, National Institute of Health stroke scale, NIHSS. Okay, level of consciousness is there, orientation to questions, response to commands, gaze, visual fields, facial movements, motor function, leg, that is arm, limb ataxia, sensory, language, articulation, extinction or inattention. So why, what is important in this score? So anybody want to answer this? What is the important of this score? Why you want to know the severity of any patient having score? Shiv Shankar, but you want to
For
answer this? Yes, yes, Nisra, please.
yes, for thrombolysis, if
Mhm.
there is a mild less than 5, then or more than 25, we consider it is not useful for thrombolysis.
Very good,
Anything in between, we can go for thrombolysis.
very good, very good. So any patient less than 5 means it is a mild stroke, non-disabling, means it is not disabling stroke, mild stroke. If it is a mild stroke, we are not thrombolizing patient. Means very small, very mild neurological deficit is there, that is not hampering too much for him. So then try to avoid thrombolysis. That is the main thing. And if it is more than 25, the risk of bleeding is very high. the stroke NIH score is more than 25, risk of bleeding is more actually with the use of TPA, tissue plasma activator. So not only that, so there are a lot of things we are assessing with the NIH score system. I'll explain one by one. But at this point of time, you should know it is a severity of the score. You should know the score severity. It will tell the severity, and will assess the whether the patient we can thrombolize or not. That is the one important thing. So next immediate step, you have to do the CT scan. Once you've taken the patient, so once you see the patient, what you have to do is you have to assess the patient, diagnose it is a stroke, assess the patient neurological scale, then do CT scan and rule out stroke mimics. So this is CT scan. Why we are doing CT scan? Why we are doing CT brain?
To rule out bleeds.
Yeah, very good. To rule out bleeds. Not we are not confirming stroke here. Please remember, we are not confirming stroke here. We are ruling out bleed. Why you want to rule out bleed? Straight away management changes there. It becomes ICH. If the bleed is there, it becomes ICH, intracerebral hemorrhage. So we want to rule out the bleed before thrombolizing patient. So make sure CT scan is normal. Make sure CT scan be normal before thrombolizing. Normal, it should be normal. Sometimes we can see early signs of stroke. Early signs of stroke. Early signs of stroke is important to you should not miss this. Why I'm telling, if there is a very obvious signs of stroke is there, means patient may not be in within window period. If the patient is within 3 hours, window period is ideal window period is 3 hours. Ideal window period is 3 hours. If the patient is within 3 hours, usually we see normal CT scan, or you can see hypodensity. You can see here, this is the sulci gyri, you can see here. You can see sulci gyri nicely, you can see. But in the other part, if you compare here, there is no sulci gyri here. Okay, and small, you can see here, there is a darkish thing you can see here. There is a hypodensity is seen, not here, here this much. Can you see this hypodensity? I want you to appreciate this. Otherwise, it will be difficult for you. See here, this is a hypodensity you can see here. Here, sulci gyri is nicely seen. It is not in here. Means some differences is there in one part to other part. This patient is having right hemiparesis, so right hemiparesis or hemiplasia also. So CT brain, why you are doing? We can do MRA also, but MRA takes time. If you have CT scan brain, just go ahead and do CT scan brain. Okay, you can do MRA brain if time permits, and you can do MRA early. So I'm explaining one by one detail. Try to do CT scan brain to rule out bleed. Okay, so this you have to understand. CT scan, I'm sorry, why in CT scan, what are the early signs? They will ask you what are the early signs. In this CT scan may demonstrate subtle visible parenchymal damage. Those are called early infarct signs or early signs of ischemic injury. The sign of cerebral ischemia first few hours. So whenever there is obstruction in the blood vessel, there is a stoppage of blood flow to that area of the brain. So that part of the brain can be seen sometimes within minutes in MRI. So I'm telling within minutes, within 3 minutes we can able to see, or sometime within few hours in case of CT scan. Okay, so there is a, usually we have to do non-contrast CT, loss of gray-white differentiation. This is a very important sign, loss of gray-white differentiation. As I mentioned in the earlier CT, there was a loss of gray-white differentiation. This sign manifests as loss of distinction among the nuclei of basal ganglia or lenticular obscuration. You should know some anatomy of the CT scan brain before understanding this. As a blending of densities of the cortex or underlying white matter in insula, we call as insular ribbon sign. If please go through the in the Google, try to search for insular ribbon sign, and over the convexity we call it as cortical ribbon sign. So these are the early signs. In practically, if you're not able to understand, if there is a loss of gray-white differentiation, loss of sulci gyri, some hypodensity is there, then it is indicates of early signs. Another sign of cerebral edema is swelling of the gyri that produces sulcal effacement. As I mentioned here, there was effacement, means edematous was there. So it's seen in 67% of the patient within 3 hours. Why important? If there is an obvious sign is there in the CT scan, that may not be the candidate for thrombolysis. Please remember that there should be subtle sign. Okay. So which trial will explain this? This everybody should learn this. If you are able to try to understand acute ischemic stroke, is NINS trial, NINS RTA, RTPA trial, and ECAS 3 trial, European study. These two trial you have to understand. So the actual, why we are not thrombolizing, why you are thrombolizing when there is a actual hypodensity, they mention this. So go through this NIN trial. This is the important. Okay. Another important thing I want to explain here is, so another useful sign, please try to know, another useful sign is MCA sign, that is called hyperdense MCA sign. Usually MCA artery, if is involved, if there is a clot is sitting there in the MCA, it will look hyperdense. In non-contrast CT I'm talking, this indicates large vessel occlusion. We call it as LVO, large vessel occlusion. Whenever there is a LVO, large vessel occlusion is there, that patient may deteriorate, may not respond for your thrombolysis, or may require mechanothrombectomy. Please remember this. So large vessel occlusion typically occurs severe stroke. See, remember, whenever there we are able to see hyperdense middle signs, very commonly seen. It is not like uncommon. Independently predicts poor outcome and stronger predictor of neurological deterioration. 90% positive predictive value. Early CT evidence of more than we call, MCA territory involvement. We call middle cerebral artery territory involvement. That will divide more than 1/3, more than 2/3. Okay, more than 1/3, there is a risk of bleeding will be there. Please remember that. Smaller area, less risk of bleeding. What I want to mention here is, if there is a hyperdense sign is there, then that is a risk of, you may not respond for your thrombolysis and you have to go for mechanothrombectomy. Another important sign is dot sign, hyperdense MCA dot sign. This represent relatively lesser severe. Within the branch of MCA, you can see a clot is there, typically smaller than the thrombus in the volume of in the MCA, possibly better target for IV RTPA. So MCA dot sign has been performed angiographically. We can see sensitivity is low but specificity is high. So you can see here, this is a can we see here dense MCA sign, very classical. We can see the clot sitting in the blood flow actually go through like this, right? Blood flow go through like this. So blood is obstructing here. So this whole part of the brain is getting affected. Whole, this is gone. This is ACA territory. This is anterior community artery, ATA territory. This is PCA territory. This whole thing is MCA territory. This will be this will go for what you call ischemia. So even you can see there's a dot sign. You can see here small dot sitting here. This we can easily thrombolize. So these are the things we should know. Early signs. These are the early signs. Try to identify the early signs. So what are the other imaging modalities do you want to consider? Anybody want to answer this? Other imaging modalities. So one is CT scan brain. See, still the patient has come to emergency department. You have done examination. You have scored the severity. Then you want to know the any other imaging modality. Anyone want to answer this? Somebody want to answer? 4 vessel angio. Very good. 4 vessel angio. Yes. So please remember, when you do investigation, you should know why we are doing. Okay. Otherwise, you will not understand. So most time, what we will do, what are the tests we will do? Yes, you told CT angiogram can be done here. CT angiogram. Even most commonly done is MRI. We'll discuss about MRI. In MRI, we have, it is a time consuming actually. We should know the MRI stroke protocol, so that we should know what to be done and what exactly to be seen there. MRI stroke protocol, that we'll discuss there, so that we can easily identify the stroke. So whenever we see the any imaging, even MRI or CT scan, actually what we are seeing is, we are seeing the 1, 2, 3, 4 P's. Remember this, 4 P's. 4 P's means, one is parenchyma, early signs of acute stroke or two-route hemorrhage. Pipes means to access the extracranial circulations, carotid and vertebral artery. Why we are seeking carotid and vertebral artery? is there any clot sitting there in the carotid and vertebral artery, so that we can go for removal of that clot. And intracranial circulation to know the thrombus. Perfusion, assess the cerebral blood volume, cerebral blood flow, mean transit time. You can do all these with the technique of perfusion technique. Penumbra, very important to assess the tissue at risk of dying of ischemia. If the patient having stroke, imagine this is the blood vessel, there is a clot is there, the whole brain I'm telling, if the clot is there, the center part of the brain is gone now. There is no blood flow only. That is called complete loss of the neurons. But some part of the brain surrounding this, there is called, it's a risk of ischemia or risk of infarction. That is called penumbra. Assess the tissue at risk of dying if ischemia continues without reconvalescence. This is very important. Actually, we are not doing anything for this loss of neurons. We want to save this, which is at risk of ischemia. So actually we want to save penumbra. We have to reduce the size of penumbra. That is the main aim here. So remember 4 P's in any imaging: parenchyma, pipes, perfusion, and penumbra with respect to acute ischemic stroke. So just I want to make it easy. Now I come to the very important MRI. So I want you to learn about MRI, because MRI is now everybody is doing MRI. Without MRI, you are not able to identify what is exactly stroke. So please remember, there is a standard MRI sequence is there, that is called T1, T2 and flare. These are very commonly done. Flare means fluid attenuated inversion recovery. Fluid attenuated inversion recovery flare, T1 and T2 threshold, T1 weighted and T2 weighted. These are the regular one. These are not very sensitive. So usually we won't do this. These are time consuming and we won't do it regularly for the stroke protocol. Yes, for other things you can do it. T1, T2. First remember what is T1 and T2 and flare. Flare also relatively insensitive. Remember this. So this will take the advantage of flare, which is relatively insensitive. Most important is DWI. Always ask for DWI when you are doing the MRI. DWI plus ADC. Remember these two combination. Very important combination. DWI. DWI means diffusion immediate imaging. ADC means apparent diffusion imaging. That we'll discuss one by one. This has emerged as the most sensitive and most specific technique for acute infarct, better than CT scan or any other MRI sequence. 88 to 100% sensitivity, 95 to 100% detecting reason within 3 minutes. See, I'm telling exact time also, within 3 minutes of symptom onset. Sometimes it may take more time. Usually within 3 minutes we can detect. So anyway, patient can't come within 3 minutes. Usually it will come in 20 minutes, 30 minutes, 1 hour. You can easily diagnose stroke. But how to diagnose stroke, you should know. These are the sequence I already explained here. One is T1 weighted imaging, and that exact word is T1. Okay, T1 weighted spin echo. T1 weighted spin echo. Just remember this: T1 weighted, T2 weighted fast spin echo, fluid attenuated inversion recovery, T2 weighted gradient echo. This is called GRE. Remember this word, GRE. GRE we want to do to rule out bleeds. And another one is gadolinium enhanced weighted spin echo sequence. This also we want to rule out bleeds. I will explain one by one now. See, you can see how to diagnose this. This one. Say this is a T1 weighted. T1 weighted means you can see here. This is a fat is bright. This is a bright. Parenchyma is nothing but fat here, bright, and CSF look black here. So if it is appears like this, it is a T1. So brain parenchyma looks bright. Okay. Opposite of this is T2. This is a T1. This is a T2. Means parenchyma means fat looks dark, and CSF, that is water, looks bright. Opposite this stuff. This, just remember this if possible. Then you can go for the flare. Flare, what happens here? Flare here, what happens here? Both looks dark. Even CSF also looks dark, and CSF also looks dark, and brain parenchyma, that is fat, also looks dark. Remember this flare. Fluid attenuated inversion recovery. Just remember the words. Okay. This is nothing but GRE. Sometimes we do GRE to rule out bleeds. Small, you can see here, small blackish thing you can see. That is called GRE. We can see the bleeds. Sometimes small bleeds also we can see. But don't do all these things. When the patient comes, just do CT scan only. Just I am just explaining how to identify the. Then another one is susceptible weighted imaging, again indicates the bleeds, small bleeds. SWI. So just remember these are the sequences there. What we are doing here is we are doing the what you call DWI. DWI you can see here. This is the posterior circulation stroke. Bright. It looks like a hyper intense. Use the word hyper intense in case of MRI. Hyper intense lesion. Hyper intense. Hyper intense lesion here is there, and here you can see the MCA territory, ACA territory, and PCA territory. Okay, this is the again DWI showing the how what is the actually the principal area is when there is a blood flow to that part of the brain is stopped, brain water molecules is not coming out, so there is a restriction of the diffusion. That is nothing but diffusion restriction. Actually it indicates restriction of Brownian motion of extracellular water. That's all. That is the principle behind the diffusion weighted imaging. You can see here, here is very nice that actually you can appreciate whenever we do CT scan brain. Say you can see here there is a loss of gyra. You can see here was sulci gyra is there. Okay, gray white matter differentiation is attenuated here, or sulcal effacement. You can see here sulcal effacement is there. It is normally here. Sulci gyra nicely seen here. It is not seen. Can you see here this CT scan brain? If you see nice slowly, we can suspect if the patient having right hemiplegia. Look at the left side. There may be early signs of stroke. If you're not able to identify, if you're doubtful, quickly if your MRI is there, do MRI. DWI indicates nicely hyperintense lesions. Very nicely we can see there is hyperacute stroke. We cannot miss stroke. Okay, when there is doubtful is there. So another one is ADC. ADC is apparent diffusion coefficient. Whatever the how it looks is it looks dark here. Okay, it looks dark. Wherever the diffusion restricted area is there, that itself look like a dark in ADC. If it is called hypointense lesion. If hyperintense lesion in DWI, hypointense lesion in ADC, that means indicate acute stroke. That indicates it's acute stroke. This actual diffusion coefficient cannot be measured by DWI, so we are doing ADC. ADC map may depict the darkening within minutes of stroke onset and more sensitive than DWI. See, more sensitive. DW signal cannot be used alone to reliably estimate the infarct size. It is important to examine DWI images comparison to ADC maps. DWI and ADC together should be there to diagnose stroke. So here we can nicely see that this is the MCA territory infarct. DWI is done. There is nicely you can see hyperintense lesion. Same area if you see here there is a ADC showing acute stroke. DWI and ADC images are viewed together, and high signal in DWI, low signal in ADC indicates restricted diffusion. Pathognomic or pathological process of cell death indicates acute stroke. This is the how you can diagnose with MRI. Remember this. If you are not able to do if your CT scan is missing, you can go for this. Ideally, it is not indicated. Please remember, MRI is not indicated ideally. You have if there is a CT is there, CT is enough to tell. CT is normal. Patient having classical case of stroke, thrombolysis. There is nothing like that. Sometimes doubtful is there. You want to do MRI, you want to rule or something. Then you have to look at this. And as age progresses, you can see as age progresses, everything changes here. Look at the DW, which was bright was there, hyper intense was there, then become hypo intense as the age progresses 7 days and 30 days. ADC, which was black was there, dark was there, now becoming brighter, hyper intense. That varies. So remember this, it varies like this. Don't worry about this, the stroke. This you can go with this stroke. Hyperacute stroke means within 6 hours. Late hyperacute means within 24 hours. Okay, and I'm sorry here. Next is 24 to acute stroke, 24 to 1 weeks. See, whatever we are doing actually, this is very important time actually. Within 3 hours we want to thrombolyze. Some patient where window period will extend is 4.5 hours. Okay, 6 to 24 hours we want to go for mechanical thrombectomy. Here mechanical thrombectomy. After 24 hours not much helpful. So within 24 hours we have to do whatever you want to do. Okay, as early as possible. It should not wait for 24 hours. I will tell you. as early as possible. Time is the brain, as I mentioned, but whatever you want to do it early. Okay, this is very important. MRI, you can do MRI. What you call this? You can see dead tissue, as I mentioned here. This is a dead tissue. This is the blood clot. You can see here nicely. Blood clot is there. This is the core. It's gone now. Nothing is here. Cells are gone. Cell death is there. Neuronal cell death is there. You cannot, salvage this. But risk at ischemia, this is called penumbra. We want to save this. So we are perfusion weighted imaging. We are doing, in case if you do perfusion weighted imaging, can identify the ischemic penumbral tissue, whereas DWI depicted, whereas the DWI depicted lesions represent the ischemic core. This is a very important point here. To know the perfusion mismatch, DWI indicate the ischemic core and PWI indicate the penumbra. Therefore, PWI and DWI, perfusion weighted image and diffusion weighted imaging mismatch is there. If is larger than the diffusion lesion, means this is lesser, this is more, means perfusion at risk is more, means we can thrombolize. Have considered represent a salvageable tissue, not thrombolize, even you can go for thrombectomy depending upon the timing. This is a very important point here. So I will show you how it will be done. Remember, see, look at this, very interesting here. Here diffusion, you can see diffusion, this the restriction is this much is the core area which has there is significant cell death is there. We can something colored has been done. If you do the perfusion weighted imaging, this is the penumbra we are able to see. This much big. Actually, if you don't do anything here, this whole brain will go. So if you attempt for thrombolysis or what you call mechanical thrombectomy, we can salvage these tissues. So this is how PWI and DWI will save the patient. Okay, we have a lot of parameters are there. You can identify those parameters. This you please concentrate this here. Here what is happening? DWI is here. This much is the DWI, and PWI is also same thing only. There is no mismatch. If there is no mismatch, means this patient is not a candidate for the thrombolysis or mechanical thrombectomy, means already there is no salvageable tissues. That's how we'll identify the salvageable tissue. This is very interesting actually. We can see here. Here DWI showing this much only, very small area. Even ADC showing small area. We think it is a small area, acute stroke. This is a posterior circulation stroke. If you go for PWI, look at this whole brain is gone here. Okay, there is severe mismatch. DWI actually showing this much only. As we mentioned, DWI showing this much only the stroke. ADCY showing this much only. But if you do perfusion weighted imaging, there is a lot of area is at risk. Actually, we have to need for thrombolysis or thrombectomy. This is the ideal. This is the ideal case for therapy. Okay, that's how we will identify. Please identify why we are doing this. There is a parameters are there. You can, if you are doing in your center, you can go for this cerebral blood flow, cerebral blood volume, MTT. This is the MTT means mean transit time. We see to identify whether we can thrombolize or not. Okay, Tmax. So many timings are there. Don't worry about this. Just I'm telling how they will identify. So this is a very important point here. After seeing the thrombolysis, when to means CT and MRI, we can do other things also. See why MRI? This is very important. Some patient will come with awake, who awake with stroke. Exact time of onset we don't know. This is a gray area actually. Exact onset of stroke you don't know, but you think you can thrombolize. Okay, then how to identify the patient can be thrombolized or not is unclear time. Time is not there within it may be more than 4.5 hours from the baseline, loss seen normal. MRI you have to look at this. MRI look at the flare. If flare is negative and diffusion is positive, DWI and ADC is positive, flare is negative. I told flare is insensitive. These lesions, these called DWI flare mismatch. These can benefit from thrombal IV alteplase, but you should leave this to the neurologist. They are better people, when there is a gray area, is there whether to thrombolize or not. When you have an intensivist, within 3 hours straight away we can go for extended window period for few patients. If we exclude most of the patients, we can thrombolize. That you remember, but you should know that even the patient, this is called wake-up trial. Remember, try to read this wake-up trial. This is a very important trial, wake-up trial, which will tell you even we can thrombolize when there is a last seen normal is not known. Then other investigation, as somebody mentioned, CTA, CTP, MRA, the other perfusion also can be done. So this is about imaging. Okay, we mentioned here evaluation patient with the suspect accused. What is the immediate diagnostic studies? So this is about imaging. I told. What about blood investigation? Which blood investigation do you do for to diagnose acute, means to in the case of acute ischemic stroke? Anybody want to answer? What are the investigation? As I mentioned, do the blood glucose, very important. This is the only investigation we need immediately. Nothing else. No ECG. No.
Excuse me, sir. Actually, any stroke patient comes with ER after primary investigation diagnose. Once patient stable, we should go for carotid Doppler's,
Yeah, I will discuss that.
fasting blood frequency, 2D echo. These are the routine things. Fasting lipid profile. These are the things. Thyroid test. These are the things you should do, sir.
No, Umesh, what I'm telling is this is the time. Time is the brain. We
Yeah,
have
yeah.
the immediate CT scan, so we can
After
do
that,
all those. No, wait, wait.
after after the diagnosis, complete treatment of after thrombolectomy or thrombolysis, next day I am telling, sir, not
Yeah,
acute
I will
condition.
go through that. I will tell. See, immediately before thrombolysis is the blood glucose is the important thing. Okay.
PT, APTT, ANR, platelet, and
I will
RBS.
discuss those things, Umesh. One second. One second. I will tell you. What I'm telling is blood glucose is the most important. Don't miss this, okay? Any other investigation you want to do, you can do it, okay? There is a lot list of investigations are there. Okay, you can go through here. You can see this. Okay, now along with the blood glucose, you have to look at the saturation. Saturation is should be 94. You should maintain. You can go for electrolytes, complete blood count, cardiac markers, okay, prothrombin time, APTT as Dr. Umesh was talking, ECG, okay, hepatic function, toxicology screening, blood alcohol level, toxicology screening, pregnancy test, ABZ. So, but these are investigation, even lumbar puncture if we SH is suspected. These all investigation takes time. So what we have to do is the patient comes with the CT scan, CT brain and blood glucose. Patient should be see whether the patient is thrombolyzed patient or not. Otherwise, what you have to do is, if any confusion is there, try to evaluate immediately to get these investigations. Okay, so this is very important, but never wait for these reports. Like you don't wait for the electrolytes or complete blood count reports to should not delay the thrombolysis. That is very important. Time is the brain. Do not delay the thrombolysis. That's the only thing. Dr. Umesh want to say same thing actually, but get those reports, but try to get thrombolysis as early as possible. That is the most important. When selecting acute ischemic stroke, okay, okay, within 6 to 24 hours last seen normal, with the large vessel occlusion. This is very important. Large vessel occlusion we have, and with the anti circulation, okay, uh, large vessel occlusion is the one thing. Here we cannot, even though thrombolysis patient may not respond, that time we patient may go for, we have to get ready for mechanical thrombectomy. That is very important. So large vessel occlusion, whenever you able to see with these CT angiogram, MRA angiogram, then you have to go for mechanical thrombectomy. So that, remember that I will discuss when that, if the time permits. So in this patient, okay, we are coming to our patient now. In this patient, we have done ECG. Umesh, can you answer now? Patient is now, we have done ECG, atrial fibrillation is there, heart rate is 120, sodium 130, glucose is 1310. Creat is relative higher side, hemoglobin is okay, 1,24,000, cardiac normal, time is 8:15. What we get information from this? And I think other investigation also done ECG like this. Dr. Umesh.
Yeah. Hello.
Dr. Umesh, yeah. So we have done ECG here. See, as you rightly told, we have to do all those investigation.
Yes.
I'm not denying that. But what is here is time is the brain. So try to get the thrombolysis as early as possible. Meanwhile, do the investigations. We are not denying.
Yes.
We are telling all those investigation now. Now they have
Yes,
done
sir.
ECG here. What it indicates ECG now? What is the result?
ECG, cardiac function, any atrial fibrillation chart score you should make.
Yeah.
after getting
No, in this
ECG.
patient, Dr. Umesh, in this patient, we have seen the ECG. ECG is there in front of you.
Yes, sir.
No, no, ECG is there of the patient. I think you're not seeing the mobile. You can see the mobile. There is a
Okay.
ECG showing, atrial fibrillation here.
Yes, sir.
See, these are things you have to roll out
Yes.
because it may be cardioembolic stroke also. Okay, to
Yes, yes, sir. Yes,
cardi-
yes, sir.
cardioembolic stroke, you can see the ECG. So ECG
Yes.
done here. Now is interesting. Now you are doing all the investigation.
Yes, sir.
ECG is 9 and
It's a PCG, you should roll out any clot in the atrium, right atrium, left ventricle. It should be rolled out. Any clots.
yes, yes,
Only echo is suggested such patient
yes.
because thromboembolic stroke is possible in case of AF with a stroke.
Okay, Dr. Umesh, time suggestion is very good actually. That is very good. See here,
Uh,
what happened here while doing blood investigation, GCS dropped to 9. So who
yes, sir.
want to intubate this patient? Anybody want to intubate? Dr. Nesara, you want to intubate this patient? GCS is 9.
Any patient less than 8 is a indication for intubation. Patient is conscious and alert, maintaining saturation.
Okay,
Hello.
here what
Yes, sir.
happened? Nesara want to answer. Yes.
Yes, sir. As the patient is maintaining airway, and if there is no airway, if the patient airway is maintaining, then a saturation is also maintaining. If the chest is clear, then we have to wait, and we can go ahead with thrombolysis and assess the neurological status post thrombolysis,
Very
whether
good.
the patient is improving or not.
So always come with the ABC. Always remember ABC everywhere actually. Whichever patient you are seeing in emergency, go through the ABC. If airway is compromised, you can intubate. But here intubation, no. Even the 9, we are avoiding intubation because if while intubating you can harm the teeth, there may bleed, it may become contraindication for thrombolysis. If definitely need of airway compromise, airway need airway measure required. If compromise is there, go for intubation. So airway, that is the airway. Breathing and or saturation you can maintain up to 94. No need to give just oxygen because patient having stroke here. And BP is 200 by 110. What you want to do this? BP is 200 by 110. Nesra, what you want to do? BP is 200 by 110.
IV antihypertensive, sir, preferably IV labetalol.
Yes. This is the most important management in the acute ischemic stroke BP management. I will tell one by one. Please listen to this. Actually, it's very important. Whenever the patient is having comes with stroke, okay, look at the patient is thrombolizing or non-thrombolizing. If the patient is window period less than 3 hours or 4.5 hours extended period is there. If the patient is eligible for thrombolysis, emergency reperfusion therapy, or even mechanical thrombectomy, if BP is more than 185, 110, start giving antihypertensive to bring the BP less than 185 by 110. So target here BP important is 180 by 110. You have to remember this 185 by 110. This is the acute ischemic stroke target. If the patient is not not a candidate for thrombolysis means then no need to maintain. Even BP is higher side is acceptable. If you want to thrombolize, then this is the BP. You can use labetalol, you can use licardipine. Labetalol should be given 10 to 20 mg IV over 2 minutes. May repeat one time. Actually, ideally, you can repeat 1 or 2 times, but usually we give few more doses so that we can bring down the BP and take the advantage of thrombolysis. We can use nicardipine. Clevidipine is the best drug, not available in India. We can use this drug and other drugs, hydrolyzine, anapolid can also be maintained. Do not administer alteplase. It is a contraindication for thrombolysis. If BP is, if it is, if it is not, 1 second. If BP is not able to maintain with the, not able to maintain with the antihypertensive, then don't thrombolize. BP should be monitored every 15 minutes, 2 hours to when the start of antibiotic therapy, every 30 minutes up for 6 hours, then every hourly. Very important. This is the way you should manage the BP. Monitoring is very important. If BP is more than 180 by 230 and diastolic is more than 105, 120, Then again you can use labetalol, nicardipine and clevidipine. Still BP is more than 140, then IV nitroprusside can be used. This is how you have to escalate antihypertensive, but don't thrombolyze here because patient will bleed. Patient will bleed here. So that is one thing. What is the dose of thrombolysis? If the patient is window period, can anybody want to answer? Is this patient is on window period? Whether this patient is in window period? Hello? Yes, this patient is window period because last seen normal was 545 and patient I think he's there within 738 he is there actually within 3 hours is there. We can use Altiplase. Altiplase dose, remember, please remember the dose here. IV Altiplase 0.9 milligram per kg, maximum dose 90 milligram over 60 minutes. You have to use 10% of the dose as a bolus over 1 minute. 10% should be given as a bolus dose. Then total remaining dose should be given within 1 hour. Recommended for selected patient who can be treated within 3 hours. This is very important. Within 3 hours is the ideal, but if you want to extend window period, that is called extend window period is called 3 to 4.5 hours. That is within 3 to 4.5 hours means same dose actually. But here according to ECAS 3 we exclude some patient where we cannot give thrombolyze IV RTPA. You should remember this. More than 80 years old, patient taking warfarin, okay, is irrespective of the INR, combined history of diabetes mellitus and previous ischemic stroke, and NIH score is more than 25. This is where we'll get NIH score. I think Nesra was talking about NIH score here. So this is the risk of bleed is more. So in this patient is there, we cannot go for thrombolysis. This you should remember. Window extended window period is there. And we have to exclusion criteria is there. Here age, severe stroke, taking oral anticoagulants, and history of diabetes ischemic stroke, diabetes ischemic stroke is there. Then we cannot thrombolyze. If you exclude this, and you can go for thrombolysis. Most of the patient will be eligible for thrombolysis within 4.5 hours. But try to thrombolyze. That is very important. And if the patient is not responding, then go for mechanical thrombectomy. That is the main explanation here. Okay, and this you remember, this is also important. If in case doubtful is there, okay, within 4.5 hours patient is there, but we don't have a unclear time whether the within 4.5 hours or more than 4.5 hours is there. Then what you have to do is you have to go for DWMRI lesion. You can go for DWA flare mismatch, you can see, okay, and smaller 1/3 of MCA territory is there, no visible signal change is there on flare, then we can still thrombolyze, but take a opinion from the neurologist here, okay, very important. Mild stroke, this is one more thing. Some patient comes with a very mild stroke, like NIH score is 0 to 5, usually we won't thrombolyze. Some people we won't thrombolyze with 2 to 4 also. People are thrombolizing now. While non-disabling, if it is a non-disabling is there, there is some definition is there, please go through that. Non-disabling stroke symptoms is there, it's not recommended, okay, whether it is 3 hours less, it is not recommended, okay. Mild stroke we call it. In this patient is ecosprin is there and warfarin is there, can we thrombolyze or not? Who want to answer this?
No, sir.
Okay, ecosprin is not a contraindication. Very good. Ecosprin is not a contraindication.
But warfarin is a contraindication.
Warfarin, everybody think that warfarin is a contraindication, but according to the protocol, you have to look at the INR.
Yes, sir.
See, if it is an extended window period is there, 3 to 4.5 hours is there, then it is an absolute contraindication. But within 3 hours is there, if INR is okay, manageable, that is we can see here. If INR is less than 1.7, we can thrombolyze till that time. Yes. So you should know this is the big table is there, exclusion and inclusion criteria. Exclusion criteria make a list in your hospital. Whether any head trauma is there, it is within 3 months is a contraindication. If any ICH is a contraindication, arterial puncture is a contraindication, severe intracranial hemorrhage is a contraindication, neoplasm is a contraindication, recent surgery is a contraindication, BP is 185, 110 is contraindication, internal GI bleeding, internal bleeding is contraindication, platelet count is less than 1 lakh contraindication, heparin given within 48 hours, INR I told no more than 1.7 and PT more than 50 seconds. These are the, and glucose less than 50 is a contraindication. This is the trial, as I told, go through that trial. ECAS2 and this is the NINS trial, according to NINS trial. And related contraindication, usually related contraindication we try to thrombolize, but absolute contraindication we cannot thrombolize. Please avoid thrombolysis in this patient. Have a checklist in your ICU or emergency, do it. If the patient, once you thrombolize, your colleague want to give usual stroke cocktail, something like clopolate you want to give, and Clexane you want to give, and heparin you want to give. Anybody want to comment on this? This is called stroke cocktail. Everybody want to give ecosprin, clopolate, Clexane, and heparin.
As per new guidelines,
Yes.
heparin is no more using, sir, in stroke patient.
Good, very good.
Previously, you are used to using heparin per stroke.
Very good. See, any TPA if you given post TPA, don't give ecosprin for 24 hours. After 24 hours, we can start ecosprin. No clopolate, no Clexane, no heparin. Please don't use, and therapeutic dose of anticoagulant should not be used for the management of acute ischemic stroke. So here you have started levodopa infusion, 0.5 to 2 milligram per minute. 6 hours later, he found unresponsive to tactile stimuli. So posturing now, what you want to do now? Anybody? Patient is worsened. While doing TPA, after TPA, patient is worsened, GCs is dropped. What do you want to do?
Repeat CT brain. You should any bleed. You should evaluate.
So this is the most important thing. When you are thrombolizing, you have to see, this is the administration protocol is there, very strict protocol. Give the dose as per 0.9 milligram per kg only with the bolus dose 10%. Admit to the ICU. Well, while giving and post thrombolysis, look for headache. If the patient is having headache, that is patient may be bleeding. Get CT scan immediately. Stop altiplase. Stop immediately. Acute rise in BP, stop. Nausea, vomiting, stop. And worsening neurological examination, stop TPA. Immediately get on CT scan, emergency CT head. And examination should be done every 15 minutes, and altiplase infusion for 2 hours, means examination. After altiplase, 2 hours, every 30 minutes for 6 hours, every 24 hours later. Then BP should be maintained 180 by 105. See, 180 by, earlier I told 185 by 110 should be there before thrombolysis. After thrombolysis, it should be 180 by 105. That is the goal, should be maintained. If that is not maintaining, go for antihypertensive. Do not put Rives tube, do not put bladder catheter for 24 hours, do not puncture artery. According to CT scan, you can go ahead now. Now CT scan done with the patient. What is happening here?
Bleed
Yeah,
is there.
bleed is
Midlines.
there. Okay, bleed is there. You have to see as a critical care doctor. What you see, you should explain like this. There is a large intracerebral hemorrhage or hyperdense lesion, okay, in the basal ganglia, okay, or even you can say around MCA territory, extending to the intraventricular extension, and midline shift is there. Ipsilateral ventricle is compressed completely. So this you have to learn, and perilesional edema is also there. So this is a bleed. I see it. Patient has bled after thrombolysis. What is the risk of bleeding? Thrombolysis bleeding is there. It is 0.6 to 6%. Now they are telling 0.5%. 0.6 to 5%. 0.6 to 5% risk of bleeding will be there. So to avoid this bleeding risk, we have to follow strict protocols as I mentioned and go for thrombolysis. Okay. So this is important. Once there is a bleed is there, this is very important. Please remember this. What is happening? Stop altiplase immediately. Get CBCPT. Already you have sent. Get the report. Go for CT scan. Cryoprecipitate. This is very important because it consists of factor 8. 10 units infused over 30 minutes, 10 to 30 minutes, and onset in 1 hour, peak in 12 hours. Additional dose if fibrin less than 150. So cryoprecipitate very important, and get the fibrin level also. And tranexamic acid 1 gram over 10 minutes, or we use tranexamic acid actually until bleeding is controlled, and make sure BP is maintained. Hematology, neurosurgery consultation, supportive therapy, intubate, ventilate. I didn't explain about temperature. Always maintain normothermia. So whenever stroke is there, maintain normothermia, normoglycemia, and normocapnia. This is very important. Temperature should be maintained normal. CO2 should be maintained normal. Glucose should be maintained normal. That is to maintain for CPP. So, okay, some people instead of alteplase they use tenecteplase. Even you can use tenecteplase also. Tenecteplase nowadays it is not FDA approved, but many people use. Even we use single IV bolus. Easily we can use one bolus actually, 0.25 milligram per kg, maximum 25 milligram. Patient without contraindication can be used. So I think I'm explained up to thrombolysis, mechanical thrombectomy. Please go through what are the options available and all according to EHA guidelines. I'm stopping here. If any, if any want to ask questions, I'm very happy to answer. Anybody, anything you are not able to understand. Hello, Dr. Umesh sir, anything you want to discuss?
No, sir. Actually, 21 patient I used tenecteplase for cardiac patient. So far, no bleeding happens,
Yeah,
no event
yeah,
in
yeah.
hospital for a MI patient, acute STEMI patient.
Yeah.
But as per literature, tenecteplase works more and good for cardiac patient rather than stroke patient, I think.
Okay, see, that is the one thing. There is a every time that discussion will be there. RTPA, and tenecteplase versus tenecteplase. Even in case of pulmonary embolism, everywhere. But
Pulmonary is good, sir.
RTPA is the standard. Please remember, RTPA is the standard. FDA approved. Okay, all studies have done this only. Tenecteplase also is upcoming now. We can use it. Lesser cost can easily be given. Can be used. This I'm not telling we cannot use, but you should know that we are comparing with the TPA. Whatever we are there, we are comparing with the TPA only.
TPA is good, sir, for same as any stroke patient. Tenecteplase works good for a cardiac patient, especially as you told, pulmonary thromboembolism, acute pulmonary thromboembolism, and also in MI patients.
Okay. What about Dr. Aishwarya? Anybody want to ask any you want to this any doubts you have? Dr. Shiv Kumar, Shiv Shankar Bhatt, Dr. Shikil, Dr. Karthik Menon, Dr. Nagraj, Dr. Nesara, Dr. Richard, Sumit Charan, Sundaram. Anybody want to comment? Thanks, greatly discussed in case patient needs prolonged anticoagulation when to start. Post thrombolysis. Anticoagulation is not there. After
So one question is there, sir.
yeah,
In case of a patient with severe with IC bleed, actually you're not going to start any anticoagulants and antiplatelets.
yes. Okay. Here the question is after thrombolysis when to start. After thrombolysis, no, after 24 hours you can start echosprin. Okay. Main thing is echosprin. Yeah. Okay. Echosprin. Okay. This is the important. If the patient is not a thrombolizing candidate, you can go for echosprin 150 mg. Okay, not a candidate for thrombolysis. That we can discuss in any other discussion. We'll discuss that part. With pertaining to this anticoagulant, we'll discuss that case again. Post thrombolysis is very important to monitor the patient. Any other questions? Early recognition, 4 vessel angio. Okay, that has been discussed. If there is no more questions, I think anybody want to comment on this? Is it okay? Because we always requested to you people come up with the case studies and so that we can discuss, but there was not happening. So we thought we'll have our own cases and discuss in the even practical this part of those case. Okay, if there is no more questions, I'm going to close. Thank you so much for your time, and I'm going to close this. Thank you. Thank you.